Hello, my name is Quentin Broussard. I'm an Associate Professor of Clinical Sciences at Keck Graduate Institute, and today we will be discussing nutrition and critical care, which some of it is consensus and some of it is controversy. So our objectives for today in relation to the critical care population who is receiving nutrition support is to identify potential nutrition assessment markers in the intensive care unit. We're going to also determine macronutrient and micronutrient requirements in critically ill patients, as well as discuss nutrition support challenges in specialized critical care populations. So to start off, we kind of have to have a little bit of a historical perspective on how the evidence has developed. And one way that we can look at evidence is based on good, thorough reviews of the evidence, which is done by those who write the guidelines. So within the last probably about 13 plus years, 15 years or so, guidelines have been developed, and the last 3 iterations of the guidelines have been developed for patients who are critically ill and receiving nutrition support. These are routinely put out by the American Society for Parenteral and Enteral Nutrition, which is ASPEN, and sometimes ASPEN will collaborate with another organization called the Society of Critical Care Medicine, which is basically a critical care organization to put together guidelines for critical care patients receiving nutrition support. So you see here, this is actually the guideline from 2009. This is what the top of the guideline looks like. If you go look this guideline up, and you see the date here, May, June 2009. But later on, actually in Austin, Texas, and this was a little bit closer to now, back in 2016, they actually revealed the newer 2016 guidelines at Clinical Nutrition Week, which was more or less the old name of ASPEN's conference. So the nutrition world, ASPEN specifically, has a conference that they hold every week. One iteration of this previously was called Clinical Nutrition Week. Now it is the Nutrition Practice and Science Conference is what they call it now. So back in 2016, they actually revealed the 2016 guidelines. And these are what the guidelines from 2016 looked like. And you see the date here, February 2016. One thing I always like to point out with these guidelines, as well as the guidelines we're going to talk about from 2021, is that pharmacists are involved in the making of these guidelines. So you see PharmDs here, you see MDs, you see RDs, which are registered dietitians, you see PhDs in some cases, who may also have a specialty. You also see nurses here, registered nurses. So you see that this is truly an interdisciplinary team that came together to put together these guidelines based on the evidence that was available at that time. So what did the 2016 guidelines have? So the 2016 guidelines were a very, very comprehensive document in regards to answering a lot of questions that are commonly faced in critical care nutrition. So they talked about things such as nutritional risk assessment. They talked about the basics of protein and fat requirements. They mentioned gastric residual volumes, which we know are no longer recommended, and this was actually the guideline that, made the recommendation not to measure gastric residual volumes anymore. They also make, other recommendations about things like immunonutrition, adjuvant probiotics in a critical care population, surgical population sepsis, and other special populations. So we're not going to talk about every single one of these topics today, but we are going to talk about a few select topics that are on this list, including nutritional risk assessment, protein and fat requirements, and special populations. So you might be wondering, why are we talking about the 2016 guidelines whenever you've told us that there are guidelines for 2021? Well, yes, there are guidelines for 2021. However, whenever we're assessing the actual guidelines, we have to assess what the guidelines we're actually looking at. So guidelines don't always look at every single facet of patient care respective to even nutrition sometimes. Just like other guidelines might only answer certain questions that are related to certain areas of patient care within a disease state or within a certain area. So the 2016 guidelines were one of the biggest, comprehensive, and most recent documents that were published to actually show us how nutrition works, or how nutrition should be guided in more recent times. And obviously, gastric residual volumes were not recommended, and they still are not recommended. Now, the guidelines for 2021, which you see here, also had a multidisciplinary team involved. And you see also, again, that pharmacists were involved with the development of this guideline. But when we look at this guideline, if we look and see what is actually in the contents of this guideline, we see that there's even less content that is actually covered in this guideline. So they do talk in this guideline about updated calorie requirements. They look at concepts like, do higher protein goals, are those better than lower protein goals? Are EN and PN usage adequate in critical care populations? In patients who are not able to supplement themselves fully on enteral nutrition or oral feeding, is parenteral nutrition acceptable in a supplemental fashion where we're not necessarily feeding them in a way that is 100% of their needs by parenteral nutrition, but we're giving them extra calories to meet their actual goal. And then they also have a statement about fat emulsion composition. So you see here that everything that was covered in the 2021 guidelines in terms of the major points either was not necessarily addressed in the 2016 guidelines, or it was addressed and there might have been updates. However, not everything that's in the 2016 guidelines is in the 2021 guidelines. So whenever we're looking at evidence, we still go back to the 2016 guidelines for questions that might not necessarily be answered in the 2021 guidelines, because some things may have not changed drastically, or there's not really much evidence that has been presented to actually make a new statement about it. So that's why we, even though we have the 2021 guidelines, we still might go back to 2016 to look. So the areas we're going to focus on today in this presentation are updated calorie requirements and fat emulsion composition. So basically what kind of fat emulsion is recommended to give in critically ill patients. So let's first talk about nutrition assessment markers. So in regards to nutrition assessment markers, as we're all aware, we have albumin, prealbumin, and C-reactive protein that help us determine whether or not a patient can be, or a patient is nutritionally adequate and well nourished, or at least nourished, or in some cases malnourished. And obviously we know that there are some confounding factors, especially when you have an elevated C-reactive protein. That means the patient is very inflammatory, and they might be breaking down more albumin and prealbumin as acute phase reactants. Because of this, and because that our critical care patients a lot of times tend to be more inflammatory in nature, and I won't say not all critical care patients are inflammatory in nature, these markers generally are not validated to work very well in the majority of critical care patients. So these are not recommended in either the 2009 or the 2016 guidelines. And the 2021 guidelines really don't even make a statement about them because nothing really has changed. And what I mean by acute phase proteins or acute phase responses, that whenever the patient is very inflammatory and C-reactive protein is increased, that we have increases in vascular permeability and a reprioritization of hepatic protein synthesis. And essentially what happens is a lot of prealbumin and albumin get broken down just because of an inflammatory process. So whenever you have a patient who's not inflammatory, albumin and prealbumin are proteins that are floating around in our vasculature that, give us an idea of how nourished a patient might be. But whenever you're inflammatory and the processes for making and breaking down these proteins is changed, then in that case, you can't rely on them. There are studies that support this, assessment also. So one of them was actually done in 2012. Use of prealbumin and C-reactive protein for monitoring nutrition support patients and adults receiving enteral nutrition in an urban medical center. So what they did in this study is they looked at prealbumin and CRP levels taken at different times and at different levels of caloric intake, and then they analyzed the trends. So this is actually the table of the results that they had from that study. And you see here that there's lots of different numbers here. And these boxes are just going to indicate more or less where, trends may or may not be happening. So in some cases you see prealbumin going up, but you see CRP going down. But it's not always concrete, say for that third red box right there that we see, the CRP doesn't really correlate well with the prealbumin per se. And also, depending on the amount of calories and protein that we're giving a patient, it doesn't also always correlate very well, because even in that third box again, we see that we're giving more and more, calories and protein, but the prealbumin basically stayed the same in the patients that were in the third group taken at times 2 and in time 3. So more or less, you don't need to memorize any of these numbers per se, but the main thing to kind of get out of this is that CRP and prealbumin don't really correlate well, especially when CRP is elevated. So what they concluded in this study is that prealbumin may not be an accurate marker for nutrition supporting critically ill patients in the presence of inflammation, and that clinical judgment should be used to determine nutrition adequacy. So what that means is that we should be looking at other markers and potential things that might give us a hint to a patient's nourishment status or a patient's nutritional status. So, what's their past medical history? Have they had any recent weight loss that was either intentional or unintentional? What's their diet been like? What disease states do they have? Do those disease states influence a nutritional status or not? Et cetera, et cetera. So those are the things that we kind of want to keep in mind. Prealbumin, albumin, and CRP are not going to be, the telltale signs, and they're not really great in a critical care population, particularly in patients who are inflamed. So anthropometrics is another thing that's important to have an understanding of in nutritional risk assessment. So remember, anthropometrics are basically the measurements of a human individual. So we typically think about those as height and weight. But there's also other things like skin folds, different diameters around the body, waist circumference in some cases, et cetera, et cetera, et cetera. And one thing that we realize is that these anthropometrics, at least in the critical care population, are not really reliable in nutrition assessment of a critically ill population. And the reason why is because in a critical care population, you essentially have some kind of tissue injury or an infection in a lot of cases. This doesn't apply to every single patient. And when you have that tissue injury or infection, that can lead to an inflammatory response, cytokine production, and that leads to alterations in hepatic protein synthesis, just like we talked about with the albumin and prealbumin earlier. Now, there are newer assessment markers that are out there that have been developing over the last, many years. And a lot of these are actually, inflammatory markers, but some of them might have a link to nutrition potentially. So those are things like calcitonin, interleukin-1, interleukin-6, tumor necrosis factor, citrulline, CT scans, and ultrasound. So one that we're going to talk about specifically is ultrasound. And if you're familiar with ultrasound, ultrasound is more or less a visualization of certain parts of the body. The most common use that we typically think of with ultrasounds is like fetal ultrasounds, for example. So if a pregnant patient is coming in to basically get a checkup with her OBGYN, and they examine basically what the fetus looks like. A lot of times they will use ultrasound to get a visualization of that. And this is kind of how ultrasound can actually be used in a nutritional method. So you don't necessarily need to know a lot about this. You just need to know kind of that this exists. But they can actually do some specific measurements to actually look at the distances between, the top of the skin, for example, as well as tendon length. And that can actually correlate, pretty decently to nutritional status. Now, obviously, you're going to have a lot of training to do this type of assessment. So that's going to be one limitation. And sometimes this stuff can also cost extra money depending on if you're doing it on many people. But there has been some evidence to show that there are some correlations with nutrition assessment and with the different lengths that a patient may have in terms of just their tendons, but also other portions of their body as well. So just be aware that this is a thing that is out there as a tool, but it's not necessarily, used widespread in practice yet. Another thing that, that is commonly addressed in critically ill patients is macronutrient requirements. So whenever we're thinking about macronutrients, one of the most common macronutrients we think about is protein. And we know that protein is important for wound healing, immune function, and maintaining lean body muscle mass. And the guidelines recommend 1.2 to 2 grams per kilo per day. That is recommended from the 2016 guidelines, and they then reaffirm, another statement in the 2021 guidelines that basically says that for now we're still going to recommend 1.2 to 2 grams per kilo per day because we don't have any evidence that says that we should go away from this at this point. Whenever we are giving protein though, and we're trying to build lean body muscle mass, we should always try to encourage patients to mobilize if possible. In a critically ill population, that this is very difficult to do sometimes. And, a lot of times critically ill patients are a lot of times bedridden. But even, getting up and basically, moving a little bit, even, sitting up at the end of the bed helps preserve those muscles. Because if we don't use muscle, we lose it. Think about bodybuilders. And I know we have Popeye here as an example, and Popeye eats, his spinach and whatnot. But kind of take it from a perspective of if you are a bodybuilder, for example, and you don't adequately take in enough protein and do workouts, for even days, weeks, or even a month, you're going to start losing body muscle mass. And because our critically ill population is a lot of times bedridden, that can cause a lot of problems in regards to maintaining muscle mass. And some patients might actually lose up to 1 kilogram per day just of muscle mass sitting in an ICU bed. So that's why it's always important, even if you're in the ICU or even if you're at home, not to be necessarily someone who is just, completely stationary. If you can move around and make yourself mobile, because that's going to help, try to preserve your lean body muscle mass, which will be important for immune function. So they looked at the different, needs of protein in critically ill patients. So this was a study done by Roland Dickerson and colleagues. This study was published in 2012 and looked at 249 patients with critical illness and trauma. And one way that they can actually evaluate protein needs is through a method known as nitrogen balance. So nitrogen balance is, a common, way for us to basically determine whether or not a patient is adequately getting enough protein intake. It's not, again, widespread, and not every, hospital or institution is going to do this because it can be a little bit labor intensive in regards to the actual measurements, because a lot of times different samples have to be obtained. But the principle here is that nitrogen balance is equal to nitrogen intake in grams per day, and nitrogen here is protein, minus the urinary urea nitrogen, or in grams per day, over 0.85 minus 2 grams per day. You don't need to know this formula. The main thing I would get from this is that nitrogen balance is a way for clinicians to assess protein adequacy. And, in some patients, we want to have certain goals for that. So I would just be aware of its existence here, but you don't necessarily need to know this formula. And with the labor-intensive part that I was addressing earlier, you see that part of it is urinary urea nitrogen. They actually have to measure that from the urine. So that can be kind of labor-intensive in trying to measure. So what Dickerson and colleagues actually showed is that with this graph on the left, you see protein intake versus nitrogen balance, that the more protein intake someone took in, the closer that their nitrogen balance got to zero. And that is ideally what we want in a lot of patients, is our nitrogen balance goal to be close to zero. And you see here that starts to occur, after a patient in some cases gets 2.5 grams per kilo per day. Now keep in mind the patient population was critically ill patients and trauma patients. And trauma patients might have a little bit different goals in terms of their protein, so keep that in mind as you're assessing these results. But more or less what the study showed was that increased protein led to better nitrogen balance. And nitrogen balance is more or less a surrogate marker of, adequate protein. And this study is an example of why that is. Another macronutrient that we focus highly on is intravenous fat emulsion. So fat emulsion traditionally contains omega-3 fatty acids and omega-6 fatty acids. So those are known as alpha-linolenic acid, and omega-6 is linoleic acid. And these fatty acids actually help us prevent essential fatty acid deficiency. However, certain omega acids and certain omegas actually will be very inflammatory to a patient. And because of that, they might actually put a patient at increased risk for infection. So the question kind of, goes, should IV fat emulsion be given during the first week of an ICU stay? Because that first week of an ICU stay, patients a lot of times, not all patients, but some patients are very inflammatory, particularly infected patients, especially septic or septic shock patients. And is it going to be a higher risk to give them fat emulsion, which is potentially also pro-inflammatory, or not? So there are studies that actually have looked at this. Battistella and colleagues did a randomized controlled trial in 1997, which was many, many years ago, looking at polytrauma patients that got parenteral nutrition. And they looked at patients in a way such that one group got standard fat emulsion versus having fat emulsion withheld for 10 days. And keep in mind that the standard fat emulsions that were available back in 1997 were soybean oil based primarily, so things like intralipid. And these patients got the same amino acid and carbohydrate doses. So looking at fat emulsion versus no fat emulsion is what this study really looked at. And what we saw with this is that whenever patients were given lipid, that their length of stay actually tended to be longer for hospital length of stay and ICU length of stay, and their days of mechanical ventilation actually looked to be longer, and that was statistically significant with p-values of less than 0.5 across the board for those outcomes. Now, if we keep looking at the other outcomes for Battistella and colleagues, if we look here for pneumonia and line sepsis, pneumonia technically, if you're using a value of p is less than 0.05, technically was not statistically significant, but it might be clinically significant because you still had about 27% of your patients in the lipid category get pneumonia versus 14% with no lipid. And the same kind of tendency was seen whenever you gave lipid, that there was a higher risk of infection. But with the other types of infection that you see here, it wasn't as high, or it wasn't really of statistical significance per se. And keep in mind that this sample size was relatively small. They only looked at 57 patients, so it's kind of hard to really detect a difference on all outcomes. But we did see, pretty decent, tendencies with pneumonia and line sepsis. and total infectious complications at the bottom. So they also looked at another study by McGowan and colleagues, which was done in 2000. And more or less what they saw with this was that with this chart that's on the right here, that whenever they, compared the two studies to, and basically analyzed the two studies in a meta-analysis type of way, they actually saw that it favored not giving patients lipids during the initial part of a patient's ICU stay. But you see here that both studies actually intersected the risk ratio of 1, which means that it would statistically not be significant for both studies individually. However, when you look at both studies together, it favors without lipids. So it's kind of ambiguous about what's actually going on here. And you see here the risk ratios with Battistella and McGowan's studies, were not favorable towards patients that, were receiving lipids. It was better without lipids, with the overall stratified risk being 2.05. And that number did not intersect, that confidence interval didn't intersect 1 for the 95% confidence interval. So that data was analyzed for the 2016 guidelines, and they suggested in 2016 to withhold or limit soy-based IV fat emulsions, such as intralipid, during the first week following initiation of parenteral nutrition in critically ill patients. And their evidence was very low, obviously, because we saw that there was ambiguity there on the last slide. Now, the 2021 guidelines, one question that they were kind of looking into is, can, mixed oil IV fat emulsions, such as SMOF-lipid, for example, and there are others that are on the market currently, but SMOF-lipid being probably one of the most common ones, can these, fat emulsions be given? And, what the previous guidelines had said, it was more or less that there wasn't really enough data to say that we can or can't. And now with, 5 years passed between the publication of both of these guidelines, they say that, it is adequate to give, mixed oil IV fat emulsions. But they also kind of make a statement and they say that, you could give technically intralipid if you needed to, but this, again, is weak data, and the evidence is relatively low for this statement. We still kind of need to shake things out in general. But in general, for, most patient populations, most commonly in practice, we're going to see either a soybean oil fat emulsion be used like intralipid, or a mixed oil fat emulsion be used like SMOF-lipid. Other fat emulsions like clinolipid and omegavin aren't as highly used in the market from what I've seen from my experience personally, just because of traction as well as probably FDA approval as well. SMOF-lipid was, I believe, the second lipid formulation to actually get FDA approval after intralipid, and that took, many, many years. But SMOF-lipid is beneficial, and it can be beneficial in a way because it does have 4 different types of fat in it versus intralipid where it's only the soybean oil base. With SMOF-lipid, you have soybean oil MCT, which is medium chain triglycerides, you have olive oil, and you have fish oil. So obviously, that might not necessarily be great for patients who have true fish allergies, but the overall population, most of the time, you're not going to see that very often. So a lot of places have actually gone to using these mixed oil IV fat emulsions because there's less soybean oil associated with it. And with less soybean oil, you have less of those specific omegas that cause a pro-inflammatory response. The next thing that we're going to talk about is calorie requirements. So in regards to calorie requirements, we know that the main methods of determining calorie requirements are indirect calorimetry, weight-based equations, and predictive equations. With indirect calorimetry, we consider that our gold standard. And what indirect calorimetry does is it measures oxygen and carbon dioxide exchange via the formula that you see here. This is a formula that you don't need to memorize, but you just need to be aware that it exists. So remember that with indirect calorimetry, we are measuring someone's oxygen carbon dioxide exchange over a certain period of time, because macronutrients, such as carbohydrates particularly, but also fat and protein, can give off basically oxygen and carbon dioxide, specifically carbon dioxide, because what our bodies do is our bodies actually will go through a process called combustion where we make carbon dioxide and water. So anytime we break down macronutrients, that is one of the big chemistry processes that happens in our body. So whenever carbon dioxide is basically produced in our body from, metabolism and breakdown of food, we have to basically get rid of that carbon dioxide somehow. And the way that we get rid of that carbon dioxide is through breathing it out. So that is why indirect calorimetry is used as a measurement of energy expenditure, because if you are breathing out a certain amount of carbon dioxide, that is a surrogate marker for how much you are actually expending energy-wise. So we use indirect calorimetry in, many different clinical scenarios, particularly when predictive equations are inaccurate or weight-based equations are going to be inaccurate. So those can be seen in morbidly obese patients or patients that have lots of comorbidities. If you have a failure to respond to nutrition support, as well as if you have metabolic and respiratory arrangements, specifically in critically ill patients that get very, very complicated. Now, whenever indirect calorimetry is done, technical expertise is needed, and the process is expensive because it does require a special machine. And obviously, it requires time from someone who's trained to do the indirect calorimetry test. Now, any healthcare provider technically could do the indirect calorimetry test if technically trained to do it. The thing is that a lot of hospital institutions, aren't willing necessarily to put up money, particularly for these very, very, very expensive machines. So if your institution has this, that's fantastic. But if they don't, it's okay. You can still get by in some cases with predictive equations or weight-based equations, though they might not be as accurate. This is what the indirect calorimetry machine looks like. So usually a patient will be hooked up, and this is actually a smaller version. Sometimes I've seen indirect calorimetry machines that are much bigger. And what they can do is they can actually be hooked up to a machine here. You see that the patient is hooked up to a mask in this case. And a sample is going to be taken from the patient for about 30 minutes to an hour. And the machine really wants a steady state of where the patient is actually breathing at. So usually that steady state will need to be achieved for multiple minutes before accurate calculations are done. So that's why it takes a little bit of time, because patients may be breathing differently at different times, especially if they're aware that they are being tested for their breathing. Now, there are limitations to indirect calorimetry, so this is very, very important to know, hint, hint, star, star. In our critically ill patients, a lot of times they do have problems with oxygenation status. And if you have a major problem with oxygenation status, that is going to limit you in your ability to use indirect calorimetry on these patients. So if you are on a ventilator and you have an FiO2 need on the ventilator at 50% or more, or a positive end expiratory pressure of greater than 10 centimeters of water, these are ventilator settings. Those are what are considered high ventilator settings. In those cases, we usually do not recommend indirect calorimetry. Indirect calorimetry is, in that case, limited for patients. Additionally, if a respiratory rate is greater than 30, that's obviously going to hinder your oxygen carbon dioxide exchange measurement. If your heart rate is 130 or your MAP is less than 60, that indicates more or less a stress state where your oxygenation can be, affected. Agitation. If you've had continuous hemodialysis, such as CRRT, for example, or if you're within 3 hours of intermittent hemodialysis, that is also a problem, because during dialysis, a lot of blood is basically being taken off of the patient and being centered back after it is filtered and goes through a cleaning process. And that can obviously affect our oxygen levels that are in the body. Additionally, hemoglobin less than 8 might indicate that the patient's not able to oxygenate appropriately and might not give us a proper measurement of oxygen status for indirect calorimetry purposes. If you're within 3 hours of blood transfusion product transfusion, that could be a problem. If there is any kind of leak within the circuitry of the ventilator, or the ventilator cuff, or a tracheal cuff, or a chest tube, for example, where the circuit is not closed, if your patient is on a mechanical ventilator, that could be a potential problem, because that might hinder our ability to actually accurately measure oxygen and carbon dioxide exchange. Volumetric diffuse respiratory or oscillator use. These are basically machines that more or less can help break down things that are within our lungs. Think about, for example, a pneumonia. Some of these machines will actually apply pressure to actually break down different infection or different processes that are going on in the lungs. And because of that, if it's affecting the lungs, usually we'll say don't do indirect calorimetry. Additionally, untreated pneumothorax, which is a collapsed lung, is also a problem, because that will affect your oxygen carbon dioxide status. So predictive equations we've talked about before, but we haven't really, used a lot of predictive equations whenever we're calculating our calorie requirements, because usually, most commonly in practice, a lot of times we're going to use weight-based equations. However, there are certain patient populations where you can use predictive equations, such as Penn State, Aretin-Jones, Schwinnemer, or even non-hospitalized patients like Harris-Benedict, which is very, very commonly heard of, or Mifflin-Sajour. There are limitations, though, to predictive equation use in general. So if you actually look at a lot of different predictive equations, you'll see that in terms of accuracy, they vary in their accuracy. And a lot of these equations are, developed off of patient data. So that's why some of these equations look, a little bit weird in terms of their numbers and the parameters that they use for those equations. But one thing to kind of be aware of is that not all of them are very accurate, and it depends on what population you're really, looking at in terms of which equation. So we see here, for example, Harris-Benedict multiplied by a factor of 1.1 gives us about 61% accuracy for all patients. 61% is not that great. Whenever we're looking at patients, we want 100% accuracy typically, at least 90%. We want something that's going to be pretty reliable. But in the nutrition world, there's not always going to be something that's 100% reliable. Even our weight-based equations might, achieve about the same amount of accuracy as our predictive equations do. So depending on your patient population, you might have more accuracy with some equations versus others. And that's why, at least for my practice, I don't use predictive equations that much, honestly. But other clinicians might, because depending on whatever their patient population is and what they see has worked, clinically in practice, sometimes these predictive equations can be beneficial. So it really just depends on your patient population. But in general, though, even for these populations, you might get a maximum accuracy around 60%-ish or so. Weight-based equations are probably one of the most commonly used things in practice to determine calorie requirements. And with critical care guidelines, there's always been debates about, what is adequate, calorie requirements for patients. So in the 2016 guidelines, they recommended 25 to 30 kilocalories per kilo per day. Now in the 2021 guidelines, they recommend 12 to 25 kilocalories per kilo per day, and we'll discuss that a little bit later. But that's the new recommendation, and that's just an aggregate statement for most critical care patients. This doesn't traditionally apply to underweight or obese patients. With obese patients specifically, Usually 11 to 14 kilocalories per kilo actual body weight is used for BMIs 30 to 50, and 22 to 25 kilocalories per kilo ideal body weight is recommended for BMI greater than 50. And again, this can always vary between patient populations, and remember that, weight-based equations are not great, neither are predictive equations, but, this might be all that you have to use if you don't have access to indirect calorimetry. And again, we'll discuss the 12 to 25 kilocalories per kilo per day in a little bit. So now what we'll discuss is nutritional support and specialized critical care populations. And the first population we'll discuss is pulmonary failure. So in patients that have pulmonary failure, one question that the 2016 guidelines had was, what is the optimal carbohydrate and fat ratio for patients that have pulmonary failure? Because if we think about our patients who have pulmonary failure, if we give them lots of carbs, and carbohydrates obviously have lots of CO2 that's being given off, probably more so than fat, lots of carbs can actually potentially cause problems theoretically with our pulmonary failure patients. So in that case, is fat formulas, for example, fat enteral nutrition formula or formulas that have more fat in them for tube feeding better than ones that have more carbs? And you see basically CO2 given off by the Krebs cycle here, and CO2 also given off here. And that's why, we're kind of looking at this for pulmonary failure, is that it could be a potential issue. So one study looked at this back all the way in 1988, published in 1989, of a small study of 20 patients who got either high-fat feeds with Pulmicare versus low-fat feeds with Ensure Plus. And they wanted to look at patients who were ventilated and look at their time to extubation. So with this study, and what they found in this study was that the hours on the ventilator actually tended to correlate better in patients who had higher fat feeds than standard feeds. Remember, fat has less carbon dioxide broken down from combustion than carbohydrates do. So what this study basically, the net outcome was higher fat intake is faster time to extubation. So remember, this was from 1988. It was a very small patient population. So, it's over, 30 years later, what new data has come out since then? So they did have another study that was done a little more recently in 2003. This was by Macejo and colleagues. This was a small study of 50 patients. They looked at high-fat feeds, which in this case was NovoSource Diabet Plus, versus low-fat feeds, which was Isosource protein. So they looked at basically a population of 70 grams versus 53 grams, and they looked at a bunch of different outcomes: ICU length of stay, mechanical ventilation duration, and mortality. And ultimately what they saw was no difference. But you can kind of debate here, is 53 grams really different than 70 grams? It's 170 calories-ish difference in terms of the fat content. So more or less based on this study and based on the other study by Al-Sadi and colleagues that we saw before that, the guidelines for 2016 had made the recommendation that high-fat, low-carb proteins are not necessarily recommended in critically ill patients with pulmonary failure, just because there was really no difference per se. And I think because of this statement and a lot of other practice differences, a lot of these formulas have started to, kind of fade in terms of usage in clinical practice. Another issue that's very big in pulmonary failure is phosphorus and phosphate repletion. So phosphorus should be monitored closely and replaced when needed in a critically ill patient population, particularly those who have pulmonary failure. Because phosphate actually is a part of ATP. Remember, ATP is energy. And if we have more ATP, that promotes cellular and organ function. So Alsumrain and colleagues looked at 66 patients retrospectively, and they analyzed phosphate trends in relation to mechanical ventilation and phosphorus trends, more or less. And what they showed was that, in patients who were trying to basically get extubated from a ventilator, the higher that their serum phosphorus was in the body, the higher chance that they were actually able to extubate the patient, and that's what this graph on the right means. On the left, you see phosphorus in millimoles per liter, and those aren't necessarily our traditional conversion for phosphorus. If you multiply this by about 3 times when you see here, you actually get a more probably accurate representation of what serum phosphorus is, because remember, our normal serum phosphorus ranges between 2.5 and 4.5 milligrams per deciliter. This is millimoles per liter here, so it's a little bit different. It's about 3-fold different. But you see here, the higher that the phosphorus, the serum phosphorus was in the body, the better chance you were at extubating a patient. And that's actually a common problem in critical care patients, critically ill patients, because a lot of times they are in fight or flight mode and they are using a lot of ATP. And because they are making lots of ATP in the process, they suck out phos. And because of that, we need to be very on it whenever we're replacing phosphorus in these patients. Next population we'll talk about is renal failure. Now, with renal failure patients, the 2016 guidelines suggested normal protein for critical care patients and a calorie goal of 25 to 30 kilocalories per kilo per day requirements in AKI patients in the ICU. And KDIGO also kind of makes similar recommendations in terms of the calorie requirements. But things that we have to kind of keep in mind when we have these patients who are on dialysis is that 10 to 15 grams of protein or more is lost as a result of continuous renal replacement therapy, or CRT, because that dialysis is going continuously and we do lose a little bit of protein. Even though dialysis a lot of times does not filter off protein very well, it still takes some off of the patient. And patients who get frequent hemodialysis, such as daily or CRT, might have prior protein needs up to 2.5 grams per kilo per day. So, whenever I think of a dialysis patient, I automatically think of 1.2 grams per kilo per day minimum for most dialysis patients. But for CRT patients, their need is going to be even higher because more of it is being taken off. And frequent hemodialysis patients might need more also. Hepatic failure is the next population we'll discuss. So hepatic failure or liver failure, one question that is kind of posed is protein restriction necessary to reduce hepatic encephalopathy? So if you think about it, with patients who have liver disease, they, in some cases, are not able to get good nutritional status in general for a liver patient. Protein restriction can actually worsen that nutritional status. It can decrease lean body muscle mass, and if you have less body muscle mass, there might be less ammonia removal from the body. So we actually see a large ammonia build up in the body, particularly when patients, are in hepatic failure or have some type of hepatic failure like cirrhosis. So patients who are malnourished prior to transplant typically actually have a higher rate of complications and a decreased overall survival rate. It's correlation, not necessarily causation. But if you are malnourished, it's something that we should probably address before, actually, considering transplant for a patient. So it's very important that we feed these patients, because some people might be wanting to limit the protein with these patients, because the thought is that if we give more protein, that there's going to be more ammonia floating around the body. And that really isn't really the best clinical case. Really, the recommendation or the suggestion is to avoid restricting protein in patients that have hepatic failure, particularly those who have hepatic encephalopathy and an increased ammonia level in their body. Last population, or the last big population we'll talk about is sepsis, and we'll kind of tie it into the overall critical care population. So sepsis, recommended protein, again, 1.2 to 2 grams per kilo. But in our sepsis patients, because they are highly inflammatory, sometimes utilization of certain macronutrients might be altered in our inflammatory patient populations, particularly in sepsis patients, because they might not be able to necessarily either metabolize macronutrients appropriately or eliminate macronutrients appropriately or break down macronutrients appropriately. And remember, we talked about there are complications of overfeeding. And in some cases, overfeeding might even be normal feeding for a normal patient who is not sick. Um, so there's always been, the concept of should we not feed patients as much whenever they come into the ICU, particularly when they are very hyperinflammatory and they have particularly a higher disease burden a lot of times whenever they come into the hospital after or before major interventions are taken to save a person's life. So a concept called trophic feeding, which is also known as trickle feeding or permissive underfeeding during the initial phase of sepsis, and really in regards to inflammatory diseases in general, may be beneficial for patients. So we can define this in a bunch of different ways, and depending on what resource you look at, they will define it in different ways. Trophic feeding might be only 10 to 20 mils per hour of a tube feeding formula, or it might be 500 kilocalories per day, or around that amount, give or take a few hundred calories, but usually not more than 1,000 calories per day. So it's kind of the equivalent of a few Snickers bars. And obviously our goal is to get the patient to goal, at least 80% of their target energy intake over the first week, or what their full energy intake would be. So there are many studies that have actually looked into this concept of trophic feeding, trickle feeding, or permissive underfeeding versus normal feeding. One of the studies that looked at it was the PERMIT trial. This was done by Arabi and colleagues. And they did a randomized controlled setup that looked at permissive underfeeding versus standard feeding. A lot of these patients, about a third of them, actually had severe sepsis per the old definitions of sepsis. And their outcome was looking at mortality, mechanical ventilation duration, length of stay, and other findings. What this study actually showed, and you see that it was actually published in New England Journal of Medicine, if we look at all the p-values here regarding, patients that were getting permissively underfed versus standard feeding, if we look at every p-value here, there was only one p-value that was statistically significant, and that was the incidence of renal replacement therapy. And we saw that there was actually a higher incidence of renal replacement therapy in patients who got standard feeding versus permissive underfeeding. And it was, statistically significant. It was 11.4% versus 7.1%. So that could be clinically significant as well. You see that there were a lot of patients in this trial. There were 448 in the permissive underfeeding group and 446 in the standard feeding group. More or less what I get from this data here is the only difference was renal replacement therapy incidence. So when did they need dialysis, yes or no? That's what this is answering here. But you see, everything else was very similar between the groups. Death, duration of mechanical ventilation, ICU free days, ICU length of stay, and incidence of, electrolyte disorders and other outcomes that you see here, certain types of infections, didn't really, have much difference, if any difference at all. So based on this study, as well as based on many other studies that have been done, and there have been a plethora, but that was just one example, was Arabi and colleagues, the 2021 guidelines actually made a change, and they said that there are no significant difference in clinical outcomes found between patients with higher versus lower levels of energy intake. And we suggest feeding 12 to 25 kilocalories per kilo. The range of mean energy intakes examined from all of the studies that they looked at in the first 7 to 10 days of an ICU stay. Keep in mind that this statement doesn't apply to just sepsis patients. It applies to all critically ill patient populations. So this can kind of be a little bit controversial because different critical care populations are going to obviously need different types of calorie requirements. A surgery patient, for example, might need more calories than a non-surgical patient, for example. So one thing that the guidelines do say is that it's important for the clinician to exercise clinical judgment whenever you're making that assessment. So whenever we've looked at patients, that, were in the critical care unit, sometimes 12 to 25 kilocalories per kilo in the first 7 to 10 days is adequate, but sometimes you might need more in some critical care populations. Particularly those who are non-inflammatory. If they're not inflammatory per se, and feeding is not necessarily going to hurt them more, I would still potentially advocate for 25 to 30 kilocalories per kilo, but this is just what the guidelines say. So keep that in mind, that guidelines are a guide. They are not always the definitive thing that we do for every single patient. So overall conclusions that we get from this presentation is that there's pretty much a consensus that traditional nutrition assessment markers like albumin, prealbumin, and CRP are, not always, reliable, but there are newer markers on the way, to hopefully widespread practice like ultrasound potentially. Indirect calorimetry is still the gold standard for calorie requirements. Protein administration should be optimized in most patient populations to improve outcomes. With critical care, it's 1.2 to 2 grams per kilo per day. And trophic feeding, permissive underfeeding, or trickle feeding may be considered in the initial stage of critical illness, particularly for those patients who have an inflammatory process. Usually I think of infection as probably one of the most common ones. So 12 to 25 kilocalories per kilo per day might be adequate for patients in their first 7 to 10 days of ICU stay in some patient populations. Here are the references, second page of references. And if you have any questions regarding critical care nutrition, please let me know. Thank you and have a great day.